Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the DAR International Alliance Conference for giving me the chance to be with you today. Special thanks goes to Professor Mohammed Hassanin, who asked me to join you today. And I would like today to talk about how can insulin pump use in Ramadan minimize the risk of fasting. Technology, how it matters, the CGM, insulin pump, the impact on glycemic control, and the glucometrics. And here comes the earliest publication about the efficacy and safety of insulin pump in type 1 patients during Ramadan fasting. And actually, we have learned a lot from CGM studies, not only about the severity of hypoglycemia, but also about the rate and timing of hypoglycemia. And the most important thing that we have learned is the glycemic variability and the blood glucose fluctuations between the fasting and non-fasting hours. And actually, another publication about the glycemic control before Ramadan and the subsequent glucose fluctuation during the month of Ramadan. So, if we're taking so many risk factors about hypoglycemia, DKA, thrombosis, dehydration, as well as glycemic variability, how can insulin pump improve glycemic control? MDI giving fixed ratio between basal bolus insulin. But what about insulin pump, where you can give different basal insulins on an hourly basis? We're being asked by patients how should we manage diabetes. And again, if we looked about that, where you can look into the DAR guidelines providing how you can adjust insulin pump during fasting. But this is the basal insulin before the month of Ramadan, where you can have an excellent CGM tracing. But if you kept actually the same basal insulin before Ramadan while you are fasting, so you're having hyperglycemia as well as hypoglycemia, especially in the few hours before breaking the fast. And here is the publication of my dear friend Asma Deeb looking at about a crucial point of reduction of basal insulin and its visibility of decreasing the risk of symptomatic hypoglycemia. So now we're talking about different arguments about the adjustment of basal insulin so many times. But how do you define success in diabetes fasting? And now we're looking about the safety and danger and when you should break the fast if your blood glucose less than 70 milligram per deciliter or having hyperglycemia more than 300 milligram per deciliter. So let's take the step by step. The earlier versions of insulin pump, where you can see many publications coming from our region. And let's start with the first one, an observational report looking at 49 patients on the 722 Minimed Medtronic pump. And they have compared those who have fasted with the HbA1c before and after Ramadan versus those who did not fast. And again, you can see the non-significance between the outcomes between the two groups. Again, looking at the number of patients who have completed the whole days of fasting without breaking, you can see again almost 61% of patients were able to do that versus 18, 16, and 4%, they have missed 1 to 6 days of breaking the fast. Again, adjustment of basal insulin. You can see that almost 53% of patients, they did not have to change their basal insulin versus 47 where they had to reduce around from an actual 10, 20, 30, and 40, up to 50%, they had to reduce their basal insulin. So they have concluded that fasting during Ramadan is actually feasible when using insulin pump with adequate counseling and support. And here is another real life observational study using an augmented CGM insulin pump in 21 patients, where they have concluded that they have redistributed the insulin over 24-hour period. They have faced that they should decrease the basal insulin during the daytime of fasting hours by 5 to 20%. And they have actually compared different variables, either the BMI, the HbA1c, average blood glucose, the total basal insulin, as well as bolus insulin and carbohydrate. And again, when they have compared both Ramadan and during Ramadan variables, they had no significance. Again, concluded that insulin pump were able to adjust the blood glucose variable without any hypoglycemia. Another case here is looking at adolescent and young adults with 5 patients where they have again compared both basal insulin and the percentage of reduction of basal insulin that have ranged from none up to 25% on some patients in order to keep the HbA1c in good control. And again, they have said that those 5 adolescents were able to fast during Ramadan with no incidence of severe hypoglycemia or DKA. Another friend, Dr. Bassam bin Abbas, who has actually compared those on insulin pump programming versus those who have on conventional insulin therapy. And they have actually seen a significant reduction in the HbA1c, as well as the mean blood glucose level and the frequency of hypoglycemia in those they have used insulin pump versus MDI. And again, you can see the significant reduction in HbA1c reaching 7.8 in comparison to the MDI patient reaching 9.1%. And again, if you're looking into this conclusion, this study, they have decreased hypoglycemic episode that required to break the fast by insulin pump. Looking into the earlier versions, moving from the first models into the low suspend models, where you can have the safety of reduction of hypoglycemia. And again, we are having the publications about the effectiveness of low glucose suspend, looking at the red arrows and look the amount of the blood glucose suspension reaching almost 2 hours to avoid hypoglycemia in those patients. And actually, if we have even checked the basal insulin before and after the adjustment, you can see that it's totally different. And those were the guidelines to just that, where you can look into the basal rate. This is before Ramadan. And let's look during Ramadan. This is completely different settings where you can decrease in different percentage, looking into the reduction of basal during the fasting hours versus increasing the basal rate during the non-fasting hours. And those were the suggested guidelines by different percentages during different timing of the daytime and nighttime, according to the adjustment to avoid hypoglycemia. So moving just from talking about basal insulin into the dietary advice, definitely we give this nutritional fact, the percentage of protein, the mono and polyunsaturated fatty acids, as well as carbohydrate. And this is actually what we are facing, the hyperglycemia seeing in the non-fasting hours during iftar. So the first suggestion here was increasing the basal rate during the non-fasting hours. And then we have compared that before Ramadan, where the increment might reach 30, 40, or 50%. But actually, the insulin pump offers another option rather than just increasing the basal rate, where you can use the bolus wizard. You've got the dual and you've got the square wave. And a very recent publication a month ago about customizing the insulin pump to provide the best postprandial blood glucose level in a traditional Egyptian iftar meal, where you can have different splitting strategies. Start first giving the upfront dose, and then you can do the dual splitting by 50-50 or 60-40, and another one 70-30, with or without 20% increment versus the standard type of bolus. And the study actually concluded that you had to achieve the best physiological postprandial blood glucose values in the iftar meal, where you can increase 20% of the bolus given, and please give it upfront around 20 minutes pre-brandial, and again split this dual wave into 70-30 to optimize the blood glucose up to 4 hours. And again, moving forward and forward about the Minimed 740G with the Smart Guard, where you can have even the suspend before low. So we're not just talking about the LGS system, but even the PLGL system, where another publication was presented as an abstract looking at the efficacy of the predictive low glucose suspend feature in decreasing the hypoglycemia. And it was actually safe and did not cause any severe hypoglycemia, and a significant reduction of those number of hypoglycemic episodes, and it was published as an abstract of the conference in pediatric diabetes. And look at the blue lines. The amount of predictive low glucose suspend feature therapy that have reduced the hypoglycemic events during the fasting hours during Ramadan. So it's not just like moving from the earlier versions, the low glucose, the predictive low glucose suspend features, but even the looping system. And here is one of the patient publications and testimony that even the do-it-yourself artificial pancreas, which is a form of a hybrid closed loop system with an excellent open source algorithm, have actually determined the level of delivery of insulin to decrease again the hypoglycemia. And moving into the tandem T-Slim and the integration of the predictive low glucose suspend into the algorithm again have decreased both hypoglycemia and DKA of the patient. And what about even doing randomization of insulin pump setting, and let's see the effects. So in this publication, they have actually looked into the basal insulin adjustment versus the doing the basal insulin adjustment and add on it doing the temporary basal insulin target and even the extended bolus feature. And you can see clearly the difference in the time above range. So again, when you're doing the basal insulin adjustment, the extended bolus and the temporary target rates, this is again is associated with less time above range as well as better time in range. And this was not on expense of the severity of hypoglycemia. And again, come our dear friend Graham Petrovsky and his colleagues showing actually the case report of one of teenagers at the 670G hybrid closed loop. And again, you can see an excellent time and range during Ramadan fasting. And actually, they have suggested that to increase the meal bolus by 10 to 20%. And even you can set a temporary target if the blood glucose reached 80 milligram per deciliter, an average of 2 to 4 hours before breaking the fast. So even the 670G was feasible to conduct safe fasting. So moving to the latest version, which is the closed loop, the 780G, and how it actually affected with the kicking up the autocorrection boluses, especially during the post-iftar meals. You can see the hyperglycemia and how this hybrid closed loop system is doing those micro boluses to correct the hyperglycemia. And actually using the system, we have done publications, and with this we have done pre-Ramadan iftar, and looking those nutritional facts pre-Ramadan, how they're doing the system settings, and by that actually we have allocated patients into two groups. The first group was the control group, meaning that we kept the same setting before Ramadan. The blood glucose target was set at 100 milligram per deciliter. The active insulin time was 2 hours. And this was versus the intervention group, where the blood glucose target was 120 milligram and active insulin time 3 hours. So now we have two different settings, and we are comparing those different settings in the blood glucose target. And let's look at this very important picture. Time and range increase in the control group versus the intervention group. It was higher. And this is actually seen not only in time and range, but also in time above range. But always remember that this was not on the expense of time below range, of hyperglycemia. So, and again, when you're having the most aggressive setting in the 780G pump, when you're looking at the blood glucose target of 100 milligram per deciliter and an active insulin time of 2 hours, those are aggressive settings. But it did not cause hypoglycemia during Ramadan fasting. However, it increased the time in range and decreased time above range. And even the primary and secondary outcome have been achieved. So the time in range above and below, with no severe hypoglycemia, no DKA, no hospital admissions. So it's even for the safety outcomes that was actually seen on those patients with 780G. So always remember that customizable targets using the 780G or the closed loop system can be achieved significant optimization of glycemic control parameter. However, even with the most aggressive system settings, it minimized hypoglycemia in a real-world environment with no serious side effects. And I'm actually looking at the guidelines, looking different guidelines on how to adjust insulin pump during Ramadan, where you can see the DAR publications for management of type 1 diabetes, not only in adult but also adolescents are included. Also, there is PAD guidelines, the first consensus guidelines that was published in 2020. And just a few weeks ago, even a most interesting publication coming from our dear friend Asma Deeb, not only about Ramadan fasting, but even other religious fasting by young people with diabetes. And if you need to have more look into how to adjust the insulin pump using the hybrid closed loop system, you can look at our publication in details to have a safe fasting. So my take home message is technology is a real game changer. The pump therapy in Ramadan, either using the earlier versions, the low glucose suspend, the predictive low glucose suspend, or even using the hypoglycemia, as well as the bolus wizards, those actually provide the flexibility of insulin adjustment, as well as having the best targeted glycemic control, the best time in range, time above range, time below range, as well as reduction in the severity of hypoglycemia, DKA, and even glycemic variability. So always remember the quality of life of your patient. And always remember the new glucometrics strategies that you have to offer your patient to have the time and range above the 80% to face all the consensus guidelines of the CGM-derived metrics. And remember, with minimal system settings, In the open closed loop system, you can have same fasting. So you don't have the hassle of changing the basal insulins and increasing and decreasing the difference between the basal and bolus, and having the best glycemic profile without the ups and lows and without different glycemic variabilities. And by this, I wish you a happy Ramadan in 2023. And really, it was honored to be with you. And thank you for joining us in this interesting session, as well as the outstanding conference. And I'm actually ready for any Q&A at the end of the session. Thank you so much.